All right, welcome everybody. Thanks to Dr. Chan, Jeff, and Hillary for coordinating this lunch and learn. Essentially, the focus of the talk today will be on planning MRIs of the pelvis. We'll do a brief review of normal female pelvic and anorectal anatomy, and take a look at a number of example cases demonstrating planning for the short and long axis views of the uterus, cervix, and anal canal. And then at the end of the talk, we'll just review a couple of other MR prep related issues that also contribute to image quality, namely the use of buscopan as an antiperistaltic agent. Let's start easy. For endometrial lesions, the planning is performed in order to essentially obtain short axis and long axis oblique views of the uterus and endometrium. Primary purpose of this is to avoid volume averaging of the endometrium, which will often lie tangential to the true axial or coronal plane of the pelvis. And that allows us to best determine the depth of myometrial invasion from an endometrial tumor. So these are obviously planned off of the sagittal T2 fast spin echo sequences, which are used to delineate both the uterine lie, demonstrate the zonal anatomy of the uterus, and provide those anatomic landmarks for subsequent uterine image planning. So for these cases, a line is generally drawn, best approximating the long axis of the uterus and specifically the endometrium within the central portion of the uterus, within the midline. The coverage of the resulting long axis and short axis images should extend several centimeters above and below the uterus, which would include the entirety of the cervix along that caudal margin. If the endometrium is difficult to delineate, either because it's distorted or obliterated by uterine mass or masses, the planning line is generally drawn to best approximate the long axis of the uterus itself, again, within that midline. So again, before jumping into some example cases, let's just quickly review some of the uterine anatomy. So here we have a sagittal view on the left and then a paramidline view on the right of the uterus. So in a normal uterus, that normal zonal anatomy is well demonstrated with a high signal intensity endometrium centrally surrounded by a lower signal intensity junctional zone, and then intermediate intensity myometrium making up the remainder of the uterus. So when the uterine line is anteverted and anteflexed, as in a majority of patients, the endometrium will generally approximate the same line as the endocervix caudal to it, and will be contiguous with it. And that dark uterine junctional zone will similarly be contiguous with the dark T2 dark cervical stroma below. Below the cervix, unless the uterus is in a military position, kind of in a straight upright position, the vagina will appear angled with respect to the uterus and cervix above, and will appear as this T2 dark structure between the uterine bladder and the membranous urethra anteriorly and the rectum posteriorly. So then acquiring our long axis coronal images of the uterus. Here you can see an example of that going from cranial to caudal through the uterus, pretty much in the midline at the level of the endometrium, and then coming caudally. And then here the short axis views, again going ventrally to dorsally through the uterus. You get this nice perfect short axis view of the uterus, and allows us to kind of delineate how deep any endometrial tumor is invading into the myometrium without concern about volume averaging. So let's go through a few examples showing where one would draw a line approximating that long axis of the uterus. On the left, we see a fairly normal uterus with an anteverted lie, retained normal zonal anatomy, and here a line can easily be drawn through the center of the endometrium within the midline, approximating that lie of the uterus. Again, covering from a couple of centimeters above the fundus through the cervix below by a couple of centimeters as well. On the right, a large uterine fibroid, this heterogeneous T2 hypointense fibroid, is completely distorting the normal zonal anatomy, anteriorly displacing and compressing the endometrium, which you can see maybe a small portion of it here, more inferiorly, but for the most part, you really lose that zonal anatomy. It's hard to use the endometrium itself to draw your planning line, but here you would again essentially draw a line approximating the center of the uterus itself, again making sure that coverage extends a couple of centimeters above and below the uterus and cervix. Here, another case where the zonal anatomy is essentially distorted by this large endometrial T2 intermediate mass that's expanding the uterine endometrium quite substantially, potentially invading slightly into the myometrium anteriorly. And again, the line is drawn along the long axis of the uterine bulk, which in this case kind of remains in line with the slightly expanded cervix below. This mass is kind of bulging into the upper cervix as well, into the upper endocervical canal, but you can see it's all kind of in the same line, so you can just draw that line along the uterus, approximating the bulk of the uterus itself. Here are a couple more examples of these bulky multifibroid leiomyomatous uteruses with distortion of the associated zonal anatomy. Here, a large dominant submucosal fibroid dorsally is anteriorly displacing, compressing the endometrium anteriorly, making it challenging to again draw the line along that endometrium. But in those cases, you would draw your line approximating that long axis of the uterus, pretty much along the midline of the uterus there. On the right, here again, multifibroid uterus, but you'll notice that the uterus is anteverted but retroflexed, with the bulk of the uterus oriented dorsally, and that endometrial canal also kind of angled dorsally. So in this case, again, given that you can see this endometrium quite well, your line would be drawn approximating the long axis of that endometrium, and directed dorsally. Here, another couple of cases where the uterine zonal anatomy is relatively well preserved, but you can see retroflexed uterus in both cases. On the left here, the endometrium is slightly curved, so a little bit challenging to draw a line along the exact uterus. Theoretically, you could draw it kind of in this orientation, a little bit more in this orientation. Here, as best you can to orient the axis to the long axis of the bulk of the endometrium here. Obviously the portion of the endometrium that's most abnormal is up here in the fundal portion, where it's more thickened compared to the nice normal thin endometrium in the lower uterine segment. And here, that line would be drawn approximating again that the rough bulk of the uterine body itself, but here you can see it also approximates a tangent to that endometrial mass that's in the fundal portion of the endometrium. On the right, again, your zonal anatomy is a little bit distorted and difficult to appreciate due to this large heterogeneous T2 hyperintense lesion in the fundal region. So again, a bit challenging to see exactly where the lie is. Is it kind of this way, a little bit more horizontal? Again, generally do your best to approximate it. Some of these can be quite challenging to determine what the exact best lie is, and there's invariably going to be some degree of variability in how any given individual might plan a case. And realistically, in these more challenging cases, I would expect there to be easily up to 10 to 15 degrees of potential variation in how someone would draw a line. And generally, that's going to be acceptable. We're never going to get a perfect reproducible line that everybody's going to draw the exact same way. However, in a majority of these cases, they're going to be more straightforward. Some degree of maintained zonal anatomy that's going to allow you to pick off the endometrial line quite easily. That all being said, for the first few months, I believe that the plan is that you guys will send planning lines in Sectra, similar to what the RADs are currently doing and sending to you, and then send that case to the consult RAD at the time for confirmation. But even going beyond that initial 3-month period, obviously it goes without saying, if you ever encounter a more complex or challenging case where you're not entirely sure what that best angle for acquisition would be, feel free obviously to reach out to the consult RAD for assistance. This is going to be some degree of a learning process, and obviously we're always here to support you in that. So with that said, let's move on to planning for cervical cases. So for planning of high-res small field of view images of the cervix, as with the uterus, these are planned on the SAG T2 sequence with the line drawn along the endocervical canal to best approximate that long axis of the cervix. As with the endometrial cases, the primary purpose is to minimize volume averaging in order to best assess the extent of stromal and, more importantly, perimetrial involvement from any cervical mass lesion. In terms of coverage, it should include at minimum the entire cervix or the full extent of any visible mass within the cervix. But generally, the field of view is extended superiorly to include the entire uterus and inferiorly down to the lower vagina. So here's, in these two cases, you can see a T2 intermediate smudgy endocervical, the endocervical canal itself is this nice T2 bright line. On the left, you have this T2 intermediate smudgy mass that can be appreciated in the dorsal lower uterine cervix and bulging into the posterior fornix of the upper vagina here. But again, our axis for the long axis acquisition should remain along that long axis of the endocervical canal, with the short axis acquisition obviously perpendicular to that line. On the right, the cervix is slightly curved, more uniformly thickened along its entire length due to presumed cervical hyperplasia in this case, and the line of that long axis best approximates, again, the long axis of that thickened endocervical lining. Here we have a case where essentially the entire cervix, including the endocervix as well as near entirety of the cervical stroma, has been completely replaced by this T2 intermediate tumor, which also looks to be frankly invading the lower uterine segment above, as well as the upper vagina below, as well as extending into the perimetrium, both anteriorly, posteriorly, and obviously out of plane, but laterally as well. Here you can still make out again the relatively anteverted orientation of the cervix. The uterus itself is retroflexed, but the cervix remains anteverted. You can kind of make out a sliver of this T2 dark stroma remaining visible anteriorly, maybe a faint line posteriorly as well, with the perimetrial invasion extending beyond that. So here again, we draw that line most closely approximating the center line of the tumor replaced stroma in this anteverted cervix. Here are a couple of more cases. On the left, the cervical zonal anatomy is maybe a little bit distorted. You can still make out some portions of the endocervical canal thickened superiorly here, a little bit harder to make out inferiorly. But you can see that kind of general anteverted orientation of the cervix, which is typically the case. And here you would draw kind of that line best approximating that endocervix, or a tangent to that curved endocervix. On the right, again, a case where the cervical stroma is nearly entirely replaced by this T2 intermediate tumor, which extends into the lower uterine segment. The endometrial canal is filled with fluid above it. Inferiorly, it's kind of bulging into the upper vagina as well. And you can see a line can be drawn nicely along that bulk of the cervical tumor, which again generally replaces the normal orientation of the stroma. It'll just approximate that same orientation, and you can see generally what we would hope for planning that line. A couple of more cases of some primary cervical tumors. Again, that T2 intermediate smudgy appearance. In this case, the cervix, the orientation of the cervix appears retroverted, and a line can be drawn kind of along, again, approximating that long axis of the tumor itself. Maybe you can make out a small portion of the endocervical canal, which has a little bit of fluid more inferiorly, to kind of give you an idea of where that is starting. On the right, a more asymmetric tumor involving the anterior portion of the uterine stroma, again extending into the lower uterine segment as well as into the perimetrium anteriorly. But you can still see kind of a maintained endocervix, and the remainder of the stroma is fairly normal. So generally pretty easy to make out the approximate orientation of this line. Here's a couple more challenging cases. These are both postoperative cases, presumably post supracervical hysterectomy, where the uterus itself has been removed, but the cervix has been left in situ and has subsequently developed a tumor. Generally, the surgery is not really performed very often anymore, so this is more and more a rarity and pretty unlikely to be encountered, this type of scenario. And by all means, I would be perfectly comfortable with you guys sending these cases along to the consulted grad if you don't feel comfortable making out the line. But here on the left, you can see a little bit of fluid within the upper vaginal canal, and then this oblong T2 hypointense structure representing the in situ cervix. You can make out a tiny strip of the endocervix more inferiorly, but again, your line is just drawn along the bulk of that cervical stroma and best approximating the endocervical canal there. Then on the right, again, another case of supracervical hysterectomy with a slightly thickened lower endocervix down here. This is a challenging one to make out. There's a little bit of motion artifact, not easy by any stretch of the imagination. Some scarring along the superior margin of the cervix as well. Kind of distorts things, makes it hard to make out the normal anatomy. But here you can see this is the anterior margin of the cervix, posterior margin of the cervix. So again, your line kind of drawing along that long axis would take you into something like this. Here, just finally, a couple of cases post total hysterectomy where both the cervix and uterus have been surgically excised. In both cases, there was a question of potential vaginal recurrence. Generally, these can be acquired in straight axial and coronal planes without dedicated short or long axis imaging necessary. They'll often be protocoled as a cervical case, but realistically, we're not as concerned that with regards to getting that proper short and long axis. That being said, if you so wish, you wouldn't be faulted in acquiring short and long axis images of the vagina. Here on the left, you can see kind of that T2 hypointense vaginal vault interposed between the urinary bladder and membranous urethra anteriorly, and then the rectum posteriorly. On the right, same thing. A little bit more challenging to make out because of the degree of motion artifact, but this kind of elongated T2 hypointense structure interposed between bladder and urethra and rectum posteriorly. So moving along to anorectal planned cases, we've decided to keep rectal tumor staging cases as RAD planned, just because these will not infrequently require review of both prior imaging and or endoscopic notes to really localize small tumors, particularly post-treatment. They can be very challenging, and RADs will often miss the tumor as well. So these can be really quite challenging to correctly plan. However, fistula protocol planning is otherwise relatively straightforward. As with uterine and cervical cases, these are again planned off the SAGT2 TSE images to obtain short and long axis oblique views of the anal canal. Generally, the anal canal can be fairly easily made out, oriented obliquely to the midline. Obliquely in the midline, and a line can easily be drawn along the center of that anal canal, such that it passes through the center of the anal-rectal junction above and the anal verge below. In terms of coverage, it's important that coverage for these cases extend from a few centimeters above the anal-rectal junction along the cranial margin. Inferiorly, which is a little bit more important, the coverage should include the most inferior skin surface of the gluteal fold along that caudal margin, just because that's where a lot of these fistulas will extend to the skin surface, and we want to see exactly where the fistula is exiting. So coverage needs to include essentially all the way through that inferior gluteal fold. So anatomically, anal canal lies between the anal rectal junction above and the anal verge below, and is surrounded by the internal and external sphincters. So the internal sphincter is essentially the inferior extension of the inner circular smooth muscle of the rectum, whereas the external sphincter is composed of striated skeletal muscle and is contiguous with both the levator ani and puborectalis muscles superiorly. So anatomically, from an imaging perspective, the anorectal junction is defined as the superior margin of the puborectalis muscle, which lies essentially just below the more horizontally oriented levator ani muscles, which will take off kind of like this. So this is the puborectalis muscle and then the external sphincter below. So generally, anorectal junction is going to lie, again, the definition is the superior margin of the puborectalis, but pretty much where the levator ani is and is coming off horizontally. As a general rule of thumb on MRI, the anorectal junction is generally located along an imaginary line between the lower margin of the sacrum anteriorly. That's a little bit cut off in this image, but generally you'll see a kind of an ovoid midline sacrum sacrum posteriorly, but anteriorly the pubic bone anterior ventrally. At the level of the pubic symphysis, you'll see that as an ovoid hypointense structure, essentially from the inferior margin of that through the inferior margin of the sacrum posteriorly. Your anal rectal junction is going to lie kind of along that line. So here on the left, you can see a line drawn through the anal canal, which is again oriented kind of obliquely to the vertical plane. with the passing pretty much through the middle of the anorectal junction here, that you can make out along that midline, along that line between the pubic symphysis anteriorly through the sacrum, and then through the mid portion of the anal verge inferiorly, and again coverage extending all the way through this inferior gluteal fold, which may not necessarily be seen right in the midline, but as you scroll through a parasagittal or paramidline position, you'll pick up the gluteal fold and see how far inferiorly you need to extend. So on the right here, again, we're roughly midline on this image. The anal canal is kind of distorted in this case because of quite extensive acute on chronic fistulizing disease. But again, best approximating what you can see to be kind of a distorted anal canal here, extending several centimeters above that anorectal junction superiorly, and then through the mid portion of that inferior anal verge. And then as we go kind of to the parasagittal, you can see here the importance of, again, extending the field of view through that entire gluteal fold, as this complex fistula can be seen in that parasagittal soft tissue, extending all the way to this posterior inferior gluteal skin surface. So that's the main purpose for extending that coverage that far down. So just a couple of other quick cases, again showing the normal anatomy that you're expecting. Anal canal kind of obliquely oriented. You're going to extend from a few centimeters above that anorectal junction between the pubic symphysis and sacrum, through the anal verge, and then through the inferior margin of that gluteal cleft. Same thing on the right. Here you can make out the normal internal sphincter, and then the external sphincter outside of it. So your line's drawn through the center of that, extending from above the anorectal junction and through the inferior gluteal fold. And just a couple of final quick cases here. Again, in this case, the anal canal is slightly curved, and again, you do your best to approximate a tangent to that curvature, and extending as discussed from above through inferior fold. And same thing here, a little bit more thickened and irregular inferior anal canal, but again, quite easy to make out that long axis of the anal canal in these cases. So that essentially wraps up the discussion on planning of MRIs. So to just kind of wrap up the talk, I wanted to quickly discuss a couple of additional things that we commonly encounter in body MRI that can quite substantially impact image quality and interpretability. So as I'm sure you're all aware, buscopan is an antimuscarinic agent that we often use in imaging for its antispasmodic properties, in order to reduce bowel motion artifact for various pelvic studies and in MR enterography. The duration of action of this drug is quite short, on the order of 10 to 20 minutes. The cardiogenic properties of it can last a little bit longer, up to about an hour, but generally the antispasmodic or antiperistaltic effects are quite a bit shorter, on the order of that 10 to 15 minutes. Given that it's an anticholinergic drug, the most common side effects are pretty much the same as most anticholinergic agents, namely decreased secretions, resulting in dry mouth or eyes, some degree of loss of ocular accommodation, which can result in some degree of blurred vision, and then infrequently itchiness, drowsiness, and usually some degree of increased heart rate. Generally, in the literature, most studies have said somewhere between 10 and 20 beats per minute increased over resting heart rate. Outside of the mild common side effects, the drug is considered extremely safe, particularly at the low dosages that are commonly used in radiologic practice. In the 50 odd years or so that it's been used, quite literally millions of doses have been administered with really negligible reports of adverse events. In fact, in the 43 years from 1963 through 2006, there was only 12 adverse cardiac events that were reported in the UK, despite hundreds of thousands of doses administered over that time. Even accounting for potential underreporting, the drug's generally considered overwhelmingly safe, and really is often administered in other facilities with limited screening. But I think it's good that we do have screening just to cover our bases and make sure that we avoid any situations where there is a potential for more severe adverse effects. Because of the mechanism of action, certain contraindications are commonly cited and employed in some institutions. Really, the most common contraindication that's generally used across the board relates to the effects on heart rate, with buscopan generally to be avoided in any patients with unstable angina. So really any history of recurrent cardiac pain at rest. A history of any recent acute coronary syndrome, so any recent heart attack or anything else of that sort. Uncontrolled, generally left heart failure, but uncontrolled heart failure in general, or known, again, generally left ventricular arrhythmias. Otherwise, buscopan administration is generally considered safe in most other well-controlled cardiac issues. So, well-controlled ischemic heart disease or atrial fibrillation are not considered contraindications for administration of buscopan at the doses we use in radiology. Aside from that, there is some potential drug interactions with any drugs that can cause QT prolongation. So for this reason, some antidepressants are considered contraindicated. Specifically, it's generally the tricyclic class of antidepressants that have been well established to have a significant effect on QT prolongation. And for that reason, we don't administer buscopan in the setting of those tricyclic antidepressants. But really, most other antidepressants are considered safe. Citalopram specifically has been shown to have an effect on QT length to some degree, but not as consistently nor profound. So generally considered safe for administration. So really, most antidepressants that patients are on are going to end up being safe. SSRIs are far and away the most commonly encountered antidepressants, and those really have no known issues with buscopan administration. Other contraindications that I would consider absolute, it's usually angle closure glaucoma, and that's untreated angle closure glaucoma, mainly because of an effect of buscopan on intraocular pressure. In terms of glaucoma, really chronic open angle glaucoma is not considered a contraindication for buscopan use, but because patients often do not know specifically what type of glaucoma they've been diagnosed with, unless they're really certain of this, I generally will just avoid in those cases. And then again, one other commonly encountered or commonly cited contraindication would be in the case of megacolon, because of potential further relaxation of the bowel smooth muscle in the use of buscopan in patients who have megacolon that can theoretically increase the risk for perforation. As for other quoted contraindications, that they're more relative in nature and generally overstated, again, for the low doses that we use in the radiology department, with really little or no literature to support them. They're quoted in the drug insert, but are typically not actually applied in most radiology departments, again, owing to the low dose and short duration of action. For most of these scenarios, I generally advocate administration of Busco, but ultimately this is going to be a decision for the supervising consult rad at the time. So one thing that's commonly cited is a theoretical risk in myasthenia gravis. So myasthenic patients, there is a theoretical risk related to the anticholinergic mechanism of Busco, but in practice, it's kind of questionable, given that the primary mechanism of action of buscopan is on the autonomic system, with really minimal or no effect on skeletal muscle, where myasthenia gravis is more of a concern. That being said, myasthenia gravis is relatively uncommon, not really encountered very frequently. So generally, we just avoid use in those patients. One thing where we encounter issues more frequently is history of obstructive prostatism. So because of the effect on the detrusor muscle of the bladder, obstructive prostatism in the drug insert is considered a relative contraindication. That being said, again, because of the very short duration of action and the low doses used, this is really of a limited concern. And unless the patient's essentially in active urinary retention without an indwelling Foley catheter, which is really not typically encountered in the outpatient setting, we generally give in this context. And currently we're working on tweaking the standing protocol for this, as well as the screening form to kind of limit the number of times that we're avoiding giving in that particular context. Similarly, cases of paralytic ileus or obstructive lesions, because of the short duration of action, generally I'll personally give in these cases. Really, the only types of obstructive lesions that I will generally avoid is in upper GI obstructive lesions or dysmotility disorders like achalasia, just because there's an increased risk of aspiration on the table in those patients. But for obstructive lesions that are further down, like a simple Crohn's stricture or a history of prior small bowel obstruction, really administration of buscopan at the doses we use is considered generally safe. So one other quick thing that I just wanted to mention with regards to patient fasting status. So generally, obviously, we recommend that all patients be NPO for any contrast enhanced study, mostly due to the potential rare contrast induced vomiting and trying to avoid any aspiration with regards to that. But with regards to effects on image quality, really not much of a concern. The presence of some fluid within the bowel or foodstuffs within the bowel will generally not limit image quality to any substantial degree, with the noted exceptions of obviously in MR enterography, patient needs to be NPO, MRCP, because it's that heavily T2 weighted imaging acquisition, having that additional fluid on board can make things much more challenging to interpret. So in those two cases, I would say that these patients should entirely be canceled and rebooked if they're coming in and not NPO. So although I would say obviously we're going to continue asking patients to be NPO and providing those instructions regarding pre-examination and pre-examination fasting, I would generally say that with these two exceptions, these cases should generally not be canceled just because the patient failed to be NPO. One thing is, again, with regards to the MRCP, obviously any cases of pancreas or liver MRI that include the MRCP images, those would also kind of fall under this scope of cases that should be invariably canceled and rebooked for patient failing to be NPO. But for a routine pelvic case or routine liver, most other cases, I would say that we should be proceeding even if the patient has come in and had something small for breakfast or a coffee or something like that. And that pretty much takes me to the end of my talk. If anybody has any questions, please feel free to ask now. I'm just going to see if I can pull up the chat. I don't see anything in the chat, but if anybody has anything that they want to ask verbally or otherwise, you can always feel free to email, call, message me on Sectra. I'm happy to provide any clarification if there's any questions on anything. All right, so if there's nothing else, just like to thank you all again for being in attendance and for your attentiveness, and hopefully we can start doing some planning shortly. I'll leave it to Dr. Chan in terms of how we'll proceed with the initial stages of this, which again, I think in the first few months, we'll essentially do a double read of all the planned cases, and then beyond that, we can see how things go.
All right, thank you so much for doing the talk, Dr. Bernie, and thanks, Dr. Chan, for setting this up.
Thank you. Are you able to share the slides with us for the examples with the angles on particularly on the cervix?
Absolutely. So I'm going to send both the presentation, and then I've recorded the talk as well, and we'll upload both the recorded talk as well as just the slides. I'll provide them to Kim, and I'll let you know exactly where where they end up being stored.
Thank you, because we have a few who are unable to attend that would like to be able to see this as well.
Yeah, no problem at all.
Thank you so much.
Thanks again. Have a good afternoon, everyone.
Thank you.